to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right. Good evening, all. Welcome to the September 11th, 2024 regular meeting of the Washington Township Hospital Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, roll please.
Okay. Director Epen.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee. Present. Director Stewart.
Present.
Move on to the oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 2 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. I believe there are some speakers today. Just again want to remind all of you that whoever is speaking, we'll really appreciate if you can keep the timing to 2 minutes for each. All right, so first one is Peter Lamb. It's here.
And I think,
Before we begin, I'd like to have a moment of silence for the victims of the 9/11 tragedy. Thank you. Good evening, everybody. Honorable members of the board, Kim, Larry, Dr. Nicholson, how are you? It was exactly 75 days ago when I stood in this very podium and spoke on behalf of my colleagues. Since then, little has changed, other than the fact that more pharmacists from our department have took up jobs in other Bay Area hospitals. They cited the same reason for leaving: increased workload without extra help, the feeling of underappreciated and undercompensated. Once again, we have to scramble to hire new pharmacists, train them for 6 weeks, and pray that they will stay long enough. I can tell you right now that unless things change, this outflow of talent will continue unabated. I have been a resident in Fremont and also worked in Washington Hospital for 15 years. However, I now find myself in an unfamiliar situation. Here I am dressed in this somewhat oversized but still stylish t-shirt, waving signs and beating drums. My family, my friends, and even my pickleball buddies down the street found it entertaining, but they understand it's all for a good cause. We have been negotiating since last November, but yet we are still at an impasse with no sense of urgency. Former U.S. President FDR has once said, "There are many ways of moving forward, but there's only one way of standing still." From here on, I wish that we can move forward together and reach an agreement sooner rather than later. Thank you for your time.
thank you.
Thank you. Next we have Adanship.
Good evening, everybody. My name is Adanship Kaur. I'm a pharmacy tech from 26 years at Washington Hospital for past 6 years. Along with my pharmacy technician role, I do controlled substance audit, and we have a great pharmacy team, which I'm really proud of that. And in the recent years, pharmacies made a lot of good changes. Those changes are including 24-hour med reconciliation, tech program, 340B program, and a lot more. We have a great team here. We work as a team, and we believe in teamwork. Teamwork makes the dream work. However, due to low pay and changes in healthcare, we are losing some good coworkers, which I'm worried about that. If we continue on this path, Washington Hospital will no longer be a good place to work or nor provide a good care for the patient. Our goal is to provide good care for the patient. Patient care is the main concern. Last negotiation was during COVID, and then we heard hospital concerns and agreed to be contracts. At this point, we hope hospital listen to our concerns and give us a fair contract, which that way we can work as a great team, provide good care for the patients, and be the #1 hospital in the Bay Area. Thank you so much for your time. Thank you.
Next, we have Kevin. No?
Hello, everybody. My name's Kevin. I'm a pharmacy technician. I'm probably one of the younger ones here. Been here for about almost 3 years, coming next month. I came here with the thought of this is one of the best places to work, and I just wanted to change the scenery, thinking it was at the top of any hospital to be at. And what Adarsh touched on was that we have a med rec that seems to be the hardest job for us to do as pharmacy technicians, because we have to talk to the patients, we have to investigate, may take us days, may take us hours just to do one person, and it's a lot of stress for us to talk to pharmacies or, patient families, even going through tough times. We also have to have the ability to talk to people and the ability to cognitively know if they're able to actually tell us what meds they're actually accurately on. We do a lot of work behind the scenes, and that's only visible to us in the pharmacy, and I just wanted to bring to light that a little small part of the med rec that we do. There are other places that are getting paid more than we are, and I just know one of the people that I used to work with, less experience, less ability, getting paid more, and I don't understand why that has to be that way. We just hope it's more of a fair pay, so that we're to the standards, because I believe the people in our pharmacy are
30 seconds.
above anybody else in the Bay Area, hospital-wise. And it's really hard for us to keep losing our brightest people, and I want to be here, and I definitely don't want to leave too, and I hope, even to amongst my peers, I'm one of the brightest people here. I would hope so. Thank you for your time. I just appreciate it.
All right, Kevin, thanks. Next is Rehan Nouri.
Good evening, respected members of the board. Thank you for allowing me to speak today. I'd like to ask each and every one of you to actually go back and visit your departments that you oversee. Just have that mental picture in your mind. Ask any ICU intensivist or ER physician how handicapped they would be without their pharmacist here. Ask your chief of compliance, who's probably on the call right now, how much impact our transition of care program has had when it was in existence. I want you to ask Dr. Aftimi in the infusion center how much impact that we've had with the involvement of pharmacy, their oral chemotherapy, IV chemotherapy, and how really limited they would be without us. And lastly, I want you to ask your medication safety officer, your CNO, how the ability of the Alaris Epic interoperability program, which these two hands have built, has impacted the ability of nursing to not have to make a single medication error due to manual programs. I want you to know that all of these things that we did were not even part of our primary job description, okay? So take that into consideration, that we have done our due diligence in looking at the strategic vision that you as a board has put place, okay? Your vision was there, and we took that vision and implemented that into something greater than what you thought could have even been possible. And if that's the case, I want you to consider maybe even giving credit where credit is actually due. Two of those people who were part of the infusion center are no longer with us, as mentioned. They went to a competing hospital. But lastly, what I just wanted to say is, there has been an increased emphasis on multidisciplinary routes, okay? Right? We've been impacting with all the disciplines. And I just wanted to say that we as pharmacists, case managers, lab, and everyone that's part of our union When we go to multidisciplinary rounds, you have the physicians, nurses, and everyone else. We in this union are the everyone else. So thank you very much.
All right. So we'll move on to written communications. Shirley?
We have another group.
We have another
group. There's
Oh, I got it. Sorry.
Yeah. Is that it? Yeah.
All right. So thanks. Since we have limitation of space, I guess.
Thank you. Yeah. So just one more group? Okay, as far as I know.
You can see also afterwards, see if there's anyone online.
Okay.
Yeah.
That's the one Diet Coke.
In the fridge, maybe. You want one? You want one?
Thank you.
One of the warm ones. Don't let them shake it.
Thank you, sir. Thank you.
Please just fill in and keep along the wall there. Come on in. Welcome, welcome. Have a seat anywhere you like. Come on first. Hello. Come on in.
Don't be shy.
Have a seat anywhere you like, guys. Okay. We are so the emergency standing room.
Do you have more cards? Here.
So now, Grant come on in. Can you folks?
No, so the choir. What's this?
Two exits, wait, three exits.
All right. I think pretty much everybody's here. Yeah, thanks for being here. Sorry for the, we're kind of cramped space, so it's a little inconvenient. And the speakers, each one, we've got about several speakers. Each one will get 2 minutes. So if you can limit your time to 2 minutes, it'll be really appreciated. So the first speaker is Raj Sandhu.
Good evening, everybody. Let me introduce myself. My name is Raj Sandhu. I've been working as a lead clinical lab scientist. I've been working at Washington Hospital for 25 years. When I started working here, this was one of the best laboratories in the area. But over the years, we have lost our competitive edge. I think it's due to the low wages and working conditions. In labs, our turnover rate is very high. During last 3 years, during COVID time, we have hired 32 CLSs, and they have all left for better wages, to better our competitive hospitals, better work-life balance, and better opportunities for their professional careers. When they left last 2 years, we had to hire 6 to 7 travelers as well to stabilize our staffing so we can be operational. The reasons for people to leave are, newly hired people leaving are understaffed. We're mostly understaffed for the lab, and we're underpaid. Understaffed, we spend a lot of time training, and we don't have resources to even train, but we still strive to train our newly hired people. It's really hard to put your best foot forward when you're really understaffed and training, but we try to do it the very best way we can. Our training is a very rushed process.
30 seconds.
Due to newly designated trauma centers also putting a lot of pressure on the staffing level. We are underpaid. Our wages are 10 to 16% below the market rate that's outside. All I say is we're looking for a fair contract, and we've been negotiating for a while, so I hope we come to conclusion soon for fair salaries for our group. Thank you.
Next, we have Mark D.
Yes.
Please.
Hi, I'm Mark Diasis. I've only been at Washington for about a year and a half. Just my background, I've been to a number of hospitals, worked at Stanford, I've worked at UCSF and Young Children's Hospital. I really like Washington, and I really want to make this kind of like a forever home. But it's been really difficult because of the staff issues that we have. And in short, the staff, because we're staffed, because we're so underpaid. Like to piggyback, we've lost so many CLSs within the span of 3 years. But retaining people is actually the worst part of everything. We can't retain people. We've had people come in with sign-on bonuses. 2 of them actually returned it because they couldn't stand the working conditions. We work 12-hour shifts back to back. We try to cover because there's no one to cover one shift. Midnight comes in early, 7 o'clock. We work until like 6 o'clock in the morning. I stay from 3 to 3 o'clock in the morning. So it's a common thing and a common process. We have had 2 CLSs covered for this day alone, and we had to have 3 people for the morning just to cover our shifts for the next shift. So it's really difficult. It becomes an operational issue for us because we're so overworked, we can't do our work properly. Everything gets delayed. We're running a trauma center. You need blood to come out, you need proper results. You can't get those proper results out because you have people that are overworked or underpaid or feeling that sense of they can't complete something because they're too busy doing other things. So all we're asking is just not only better pay, but we need more people to come in and be able to retain them, and that entails with more better pay. So, thank you.
Katie?
Good evening. Thank you for the opportunity to speak today. My name is Katie, and I'm a physical therapist here at Washington, and you may recognize me because I stood up here last June. Since that night, our rehab department has lost members of our team. They have left for better pay, opportunities for growth, and to feel valued and appreciated. That is one professional a month that we've lost. We have more going away parties in our department than celebratory ones. A year or 2 before that, we lost 4 stellar therapists to Eden alone. Therapists at Eden get paid up to $20 more than us. Their hiring manager in an interview even said, "I don't know what they're doing over there at Washington, but please keep sending your people over." Happy, satisfied workers provide a stable foundation for building a talent strategy that elevates your business. You guys are running this business. Poor employee retention, which is what we are dealing with right now, leads to disrupted culture, unsatisfied workforce, loss in revenue, increase in hiring and training costs, and poor customer experiences. Our Washington Hospital value states healthcare is an intensely personal service. And despite feeling underappreciated and grossly underpaid, we all show up to work every single day, and we show up for our patients.
3 seconds.
Our dedication to our patients will be there no matter what. What we are asking for is to be fairly compensated. The rate of inflation from 2021 to 2023 cumulative was 15.4 in California. We were given 7.5 over the past 3 years. How, I ask, do you suppose we were able to afford living in this community? We're just asking to be able to buy groceries, afford healthcare, and pay for rent and childcare. It's not like we're asking for a new Lexus every year. That would be absurd. I live in this community because I want to serve this community. I don't want to have to move to Tracy or Lathrop to commute to this hospital because I can't afford to live in Fremont anymore. I do want to end this by sharing that, like this institution, I also think that healthcare is an intensely personal service. I love this job, and I really love this team. I love my patients and providing care that makes a difference in their quality of life and the ability to be a part of our community. I just want to be able to do my job and provide for myself and my family. Thank you.
Next we have Karen Manning.
Good evening. Thank you for allowing me to speak. My name is Karen Manning, and I've worked here for 25 years. I'm a speech pathologist. I really love my job, but I also have seen over the years the number of people who have left Washington Hospital for higher wages. We do so much training of young therapists who get an opportunity to come and work at Washington Hospital. They love the culture. They love that our team is collaborative and willing to teach them new skills. However, as they get trained, they then leave because of the fact that there are other hospitals willing to pay them higher wages. And that can be just very frustrating. We'd like to grow our program. In the speech therapy department, we've grown the number of modified bearing swallows we do. We have gotten new equipment. We are looking to do best practices. We have per diem employees who are from other hospitals who love our culture, but ultimately they'll say, Karen, we love working here, but we can't. We make $10 an hour, $15 an hour, $20 an hour more, even if we have to commute a little further. And we have to look at the economics. I've been here for 25 years. I'm also part of this community. This is my hospital. We have such talented young therapists coming in. We need to keep these therapists. We need to groom them. They want to be part of this community. Please, please give us a fair contract and fair wages. Thank you.
Next, Abby. 08.
Good evening, everyone. My name is Abe Maximo. I'm a PT assistant here at Washington Hospital. I spent my years building my career within these walls. I love what I do. I started here as a student 7 years ago, full of hope and passion, and I worked my way up to where I am today. This hospital is not just my workplace, it's my second home, my community. Life can be truly tragic. Anyone in this room can get in a car accident, have a stroke, get shot, and so on. We'll be there for you during the lowest of your lows. There's nothing more fulfilling than seeing a patient walk out of here stronger, healthier, and with a renewed sense of hope. We are the people that get patients to return back to their function in life, wherever and whatever that may be. But as much as I love working here, it's getting harder to make it. Living in the Bay Area is not easy. The wages we're earning here simply don't reflect the cost of living or the value of the work that we do. It's not just a number on the paycheck. It's about being able to live with dignity while doing a job we're passionate about. The retention problem is ridiculous. We've lost amazing therapists to other hospitals due to huge pay difference. It's only a matter of time before we lose another one. I worked at other places where the pay was higher, but I stayed here because this is where my heart is. I believe in this team, in this hospital, in the community we built, but that doesn't mean we should settle for less. We deserve to be paid fairly for the hard work we do every single day. We are more than just healthcare workers. We are caregivers, counselors, and healers. We don't sit behind a desk all day wearing a suit and tie. We are sitting face-to-face with our patients, providing empathy and care. I'm proud to be here, and I know many of you feel the same.
30 seconds.
But the pride in our work should not come at the expense of our well-being. Fair wages will not only help us, but will strengthen this hospital by ensuring that we can focus on what matters the most, our patients. So today we stand together, united in our message. We love this hospital, we love the work that we do, but we also need to survive. We need fair wages. This is our community, and we're here to fight for it.
Alan Liang.
Greetings all, my name is Alan. I'm a physical therapist here for the past 2 years. I was also a former rehab aide. There's a crucial issue that challenges many of us here in this room today, the need for fair wages and its effect on staff retention. We have seen a troubling trend recently. Our rehab colleagues are leaving for better pay at other institutions. This is not just an inconvenience, but has significant consequences. High turnover disrupts team continuity, incurs higher costs for having to train new employees, and negatively affects staff morale. Additionally, with rising inflation and increased family expenses, the pressure on our staff is mounting. This economic strain intensifies the attractiveness of higher paying positions elsewhere, further increasing our staffing challenges and ultimately affects patient care. As someone who deeply values my role here and envisions a future here at Washington Hospital, it is disheartening to consider leaving due to the disparity between our wages compared to other institutions. All we ask is to be compensated fairly. Fair compensation increases employee commitment, improves care quality, and fosters a positive work environment. Addressing these wage concerns will help us maintain a stable and experienced workforce, which is essential for providing consistent and excellent patient care. I plead with the board members here to support our need for fair wages. By doing so, we can create a more stable, valued, and motivated team to ensure that Washington Hospital remains a place where employees are proud to stay and grow within. Thank you.
We have Vicky.
Hi, my name is Vicki, and I've been a PT here for going on 24 years. Washington Hospital has always been a place where employees stay and retire here. We call them lifers. That's going to be me too. I'm going to be a lifer. And Washington Hospital just stuck with me. During my 24 years here, I've seen therapists come and go. But over the last 3 years, I've noticed a very sad and blaringly obvious trend, and even HR could tell you that we've lost so many great therapists, it could make your head spin. So our most skilled, well-respected, and already trained therapists are going elsewhere to make other local hospitals great. And each great therapist that leaves is a missed opportunity for Washington Hospital to stand out in patient care excellence. It's hard to get to that point of excellence when we're constantly scrambling to train new staff. And when I see our most talented team members slip away one after another, and I can't do anything to keep them here, it's truly heartbreaking. And I feel hopeless, powerless, frustrated, and demoralized. So tell me, how can we keep great therapists here at Washington Hospital? How can we give back to being staffed with seasoned lifers?
It's not very clear. Geoff? G.
Good evening. My name is Jeffrey Advincula. I'm a physical therapist and also a wound care practitioner. I have been here at Washington Hospital for 18 years. I love this hospital. I love its culture. I love all of its program, and I love its mission. Rehabilitation services are comprised of multifaceted and highly skilled clinicians. Unfortunately, a good amount of them have moved on somewhere else for a more at-market, fair, and more competitive compensations. We are highly committed and dedicated in providing care for our patients and service to our community. We facilitate, or we are involved in treatment and interventions which covers various conditions. We're talking about orthopedics, neurological, medical, surgical, complex wounds, pediatrics, and at most recent, trauma. Our role is to enable these patients to regain their functionality, independence, and quality of life. We are here tonight reaching out to you, the board, for a favorable contract agreement and fair compensation. Thank you.
Next, is it Lyrica or Jerica?
Jessica?
Is it?
Yeah, that's me. Hi. Hello, my name is Jessica. I'm a physical therapist, and I've been working here at Washington for 2 years. I help out on different disciplines of the rehab team, from the joint replacement program to the outpatient neuro rehab to critical care and trauma. I really enjoy my job. I love my rehab team, and I appreciate all the opportunities of growth that I have here. Because of these reasons, I had plans to stay for a really long time. Did you know that starting in 2016, the PT profession had to change to a minimum of a doctorate degree? The Commission of Accreditation in Physical Therapy Education has made this change after recognizing that the complexity of patient needs requires a doctorate level education. Here at Washington, we currently have 12 therapists with their doctorate degrees. So I am currently at the phase of my life where I'm trying to buy a home, start a family, and pay off my student loans. So with the rising cost of living here in the Bay Area, it is becoming very difficult to continue my journey here at Washington. Management always says that they appreciate rehab. However, I do not feel valued as we are unfairly compensated. Our rehab team works hard every day to communicate and provide quality care for our patients. Please give us a fair contract with fair wages so we can continue to serve our community. Thank you.
Next, we have Grant.
All right. Good to see everybody again. I don't think I need to introduce myself. I think everybody in this room knows who I am. So, you know, we have negotiations next week. You guys, my voice is a little hoarse because I've been out there since lunchtime, and I've been out with these folks. First off, I just want to say this is the classiest group of people that I have worked with, honestly. The most professional, the classiest. They're one of my favorite hospitals to represent. I represent 10. These are my favorite. Don't tell that to the other hospitals. But you guys are my favorite group to work with, and, you know, it's unfortunate that we can't get a fair contract for these guys. You know, it's going at almost a year, and then the attorney, you know, we had to bring in a mediator because of her behavior, the way she acted, also the way a director reacted in rehab, and unfortunately they're refuting that. They're saying that those things did not happen, they did not take place. Well, those are lies, and we have witnesses for that, and we had a big group of people within that building, so, you know, we're ready to appeal that. But what we're asking you guys to do is that the behavior from the attorney needs to stop, the intimidation, the disrespect. She didn't even show up in person to the last negotiation. She was on Zoom, probably because she didn't want to see me face to face, nor our members. So we're asking her to come in person. The second thing is, you guys know that we were out there today. We're fighting for a fair contract. We're asking for a fair contract. So based on what we see from the hospital next Wednesday, that's going to be your guys' response. So we're going to be looking very carefully, because we gave a proposal at the last mediation, and Martha did not give us a proposal back. So based on what she says, we are going to respond to that. So we're hoping that we're going to see some movement. You guys are the ones that technically are supposed to be running the hospital, so I hope that you guys are listening to these folks and that we can get a fair contract for these folks. So really appreciate your time. And the last thing that I do have to point out, unfortunately, because some of my members have pointed it out to me, is I want to say that the majority of you have been very respectful at this table. As a matter of fact, all of you except for one person. But board member Kosachenko, you like to check your phone. You like to be on your phone while people are speaking. You ignore people while you're on your phone.
I'm not a board member.
Oh, well.
I'm working for the hospital.
Okay, well, whatever you are.
I'm taking notes.
Well, whatever you are, you're on your phone the whole time and you're on your watch. And people find it disrespectful while everybody else is paying attention. So anyways, we hope that you guys come and bring a fair deal to us next week. And if you don't, then we're unfortunately going to have to escalate matters. And hopefully it doesn't have to go that way. Because I'll tell you, I got 10 other hospitals to do, and I don't exactly necessarily, you know, want to be out there. And these folks don't either. These folks worked all day, and they're spending their time after work to meet with you guys. So give us a fair contract, talk to the attorney, and if it doesn't happen, if we don't get a fair deal, then we're going to have an issue. So thank you guys, and I appreciate your time. We got
Christine?
Kristen?
Yeah.
Good evening, members of the board. I am Kristen Lynch. I'm the Assistant Executive Director at ESC. I'm very happy to be here, but I'm not happy to be here because I've been representing and working as a director with many healthcare workers for the last 20 years, with the California Nurses Association, with the Service Employees International, with the International Union, and now at ESC. And I wasn't prepared to speak today, but I felt very compelled because what I am hearing from Grant at the table, what I am hearing from members who are calling and giving their story is appalling. You cannot keep people with the wages and working conditions, and they're all connected, because if you can't keep people here because the wages are bad, you lose more people. The fewer people you have, the more people have to work. The more people have to work, the more they leave. So it's a vicious cycle that we have here. And so we're asking you to direct the people and the representatives that you have at the negotiating team that are supposed to be speaking on your behalf in the interest of staff, in the interest of patients, and ultimately in the interest of our community to do better. Take away takeaways that you haven't proposed to any other union, okay? We're not going to take retirement takeaways. Please instruct your negotiator to not use intimidation tactics that only amp up everyone. And please find a way to pay people what is needed to be able to recruit and retain. Thank you for your time.
Next is Brian Soon.
Good evening, everybody. My name is Bryant. I've been here about a year. I came to Washington Hospital from Stanford, and I was a manager for their case management department for about 8 years. I'm coming to you not as a case manager specifically, but also as a community member. I've been here in Fremont for about 30 years. My mother is a Washington nurse. My kids were born here at the hospital. I am a direct recipient of the care that you all these fine people provide, and all of you guys lead. I was encouraged when I first joined the organization. Our esteemed CEO shared a vision that was mapped out to show that we were going to implement strategic revenue strategies that centered around case management. And I was encouraged because that really wasn't the focus necessarily at other organizations. And I was hopeful. Unfortunately, at that time, a third of our staffing for case management were travelers. And then when that funding ran out, now most of our per diem staff had to step up. Unfortunately, that has also dried up. In the last year of my time, 7 out of 7 case staff members have all left, leaving us with a bare minimum of 17 staff members for the whole hospital. And as of right now,
30 seconds.
I have our ratios are now 1 to 31. Today I have my coworkers had 36 patients to themselves. We're trying to help the hospital save money, but it's very challenging, and so we are advocating for improved staffing, and we appreciate all the union members here for their support. Thank you so much.
Next is Edward.
Oh, okay, well, that's not a small responsibility. My name is Edward Glass. I work at the lab. I'm a clinical scientist. I'm probably the least senior person in this room. I haven't even been here 6 months yet. However, everyone that I've got hired on with has resigned. I don't really think this is a bad place to work. I think you have a nice facility. I think you're trying to invest money in equipment, especially for the laboratory. We're getting new analyzers next year. However, I feel like there's a massive bottleneck being created throughout the facility due to understaffing and ancillary services. So, for an example, right now we have 3.5 people in the laboratory, which means you have less than one person for laboratory department. So, theoretically, right now, if you were to get a positive blood culture, there would be no one in the laboratory to run your CBCs for the emergency department or for surgery. They would have to stop the blood culture and go do that and bounce back and forth. Maybe they'll have to go from the infectious disease lab to the blood bank, where they'll be handling transplant and transfusion material. Many facilities would never allow that, but we're kind of forced to do that here because we don't have adequate staff. Another thing that's been coming up is when we talk to management about additional staff, we're told, well, census is low. However, but for most ancillary services, such as lab, pharmacy, rehab, usually staffing is judged by units of service. How many tests you put out in an hour, how many patients you visit in an hour,
30 seconds.
how many prescriptions you fill in an hour. Census is largely divorced from our workflow, especially in lab, since I'd say probably about half of our samples do not come from this hospital. They come from our area physicians and community physicians. And it's very hard for a single person working on the bench to weigh whether a sample from ED or from a stat sample from a community physician, or if a positive blood culture or an emergency blood issue is more important. And I feel like it's unreasonable to allow someone to make that decision on the fly. I know everyone here is talking about pay. Who doesn't love more money? But personally, as a new person, what I need is more staff. That's really all I want to tell you. Thank you all.
Thank you, guys.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you.
Thank you for your time. Thank you.
Right.
Thank you. Anybody else? Are there any other?
Yeah, are there any other speakers?
No, we don't have it.
We'll move on to the written communications. Cheryl, are there any written communications?
No written communication.
Move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar?
No.
Hearing none. Does any member of the public want to remove an agenda item from the consent calendar? No? So may I have a motion to approve the consent calendar item A, Director?
Excuse me, I move that the Board of Directors approve the consent calendar item A.
Second.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Yes, next we have a presentation, and it's our DEI journey, and Gisela Hernandez is going to present, and so I'm going to give a little bit of a background about Gisela. Gisela was part of the original Diversity, Equity, and Inclusion Task Force team that was created in 2021 to evaluate how to introduce and integrate DEI into our healthcare system. Gisela led the development of the Healthcare System's Health, Equity, Diversity, and Inclusion Council, also known as HEDIC, and is collaborating with a multidisciplinary team of healthcare professionals who are strategically advancing health equity and establishing inclusive best practices to promote belonging in the workforce. Prior to her current role, I think many of you know Gisela served as our Director of Community Relations Department for more than a decade. In that role, she oversaw the hospital's internal and external marketing and communications, media relations, social media, and InHealth television station. Gisela started her career in healthcare, community, and government relations, communications, and brand management in 2004 at another district hospital in the Bay Area. She has a Bachelor's of Art degree from the UC San Diego in urban planning and Spanish literature and a minor in ethnic studies. She has a certificate in diversity, equity, and inclusion from Cornell University. Welcome, Gisela.
Thank you. All right, I'm going to share my screen here. Please tell me when you see the presentation.
Yeah, we can see it.
Wonderful.
Yeah, looks good.
All right, well, thank you for having me here to start this evening by talking a little about DEI. And I want to tell you about how we embarked on this journey. What you're seeing on screen right now is a line from the executive communication that our CEO sent to the entire healthcare system announcing this DEI as a priority. And I'm sharing it because it does an excellent job at explaining the why of DEI. So we have embarked on a DEI journey to foster a stronger, more inclusive culture where our team can reach their full potential and all patients receive high quality, equitable care. So today, I hope that you walk away with a better understanding of DEI, what it is, why we are prioritizing this work, and what it means for our patients and our workforce. So tonight's update will cover how we started the journey, why one of our first priorities focused on patient demographic information, the HEDIC that Kimberly mentioned, which is our Health Equity, Diversity, and Inclusion Council, and the work that is underway, other improvement work that is happening outside of the HEDIC, and I will also review regulatory requirements in the area of DEI. So we started the journey in 2021 by creating a task force that did a whole lot of due diligence, looking at how and why DEI supports better patient outcomes and improved patient satisfaction, and how this work also helps improve staff satisfaction and their sense of belonging. The group explored DEI efforts at other healthcare organizations, both locally and nationally. Education and trainings on various DEI topics help the group better understand the work and the many best practices that are out there, as well as strategies being used in other healthcare organizations that were already embedding DEI into their healthcare systems. And after more than 2 years of due diligence, our DEI journey officially launched in early 2023. Our CEO announced to the workforce that DEI was a priority, and the launch included announcing the new position of Chief DEI Officer to lead this work, which is the role that I'm in today. So one of the very first actions taken after the announcement was surveying our employees, our physicians, and our volunteers. A diversity and inclusion survey gave our workforce an opportunity to weigh in on their views on diversity, inclusion, and our culture. The feedback provided helped prioritize some of the improvement work that is currently underway today, and I'll share some of those later in the presentation. Also in 2023, the entire executive team from the hospital and our medical foundation went through a 6-month DEI training. All right, now I want to turn to one of the reasons that we're on this journey. DEI is a priority because it is the right thing to do for our patients, for our employees, physicians, and volunteers, and for the community. We are doing this work to give everyone an opportunity to be as healthy as possible and to have equitable opportunities and experiences in the workplace. But equity is also a priority set by regulators at the national and state level. So this slide provides a quick overview of what it will take to achieve equity in healthcare. One, we need an infrastructure, and our infrastructure is the HEDIC, which I'll go into more details in a few minutes. The council has been very strategic about the work that it has taken on. The dedicated leader is me. I'm the Chief Equity Officer in that role. And along with the HEDIC, we have a clear governance structure that is responsible for overseeing DEI system-wide. So that's not only the hospital, it's the entire healthcare system that includes our medical foundation. In the area of community engagement, number 2, I will start by saying that our community outreach team is doing an excellent job already. The priorities set by the Community Engagement Committee will further enhance our engagement with our public, with our community members. And more details will be shared later in the presentation. Number 3, we have prioritized population health by starting this journey with a focus on the collection of data. This data will help identify inequities to inform the work, both existing and future improvement. And then number 4, which is focused on people. The HEDIC's People, Culture, and Mission Committee is focused on the workforce. The committee's priorities are in direct response to the feedback provided by the workforce. They told us that they want more education and training, and more opportunities to get to know each other and to celebrate one another. They want to celebrate their cultures, their colleagues' cultures, and it is happens to be the cultures that widely represent the communities that we serve as well. So one of the early learnings is that the collection and use of data on race, ethnicity, and language is a critical part of the process of identifying health needs and eliminating disparities. We know that when we have accurate patient data, we are able to identify, monitor, and analyze disparities so that we can address and eliminate them. Data also helps identify individuals and groups that benefit from quality improvement work and other interventions. So with a multicultural community that is normal locally, and given that certain diseases have a higher prevalence in certain ethnic populations, and that many diseases affect mostly women, it's important that we take meaningful action to address inequities. But to take action, we need information. So good, reliable information about our patient population have to be a priority. And that is what is helping us uncover opportunities for improvement. So once we understood the importance of data, we knew that one of our first actions had a focus on improving the information we collected from patients. So we prioritized what we collected and how it was collected. So while we have always, as an organization, collected some demographic information from patients, we had to standardize our approach. We could no longer be okay with staff assuming anything about our patients, which had been a practice in some areas of the healthcare system. Yes, some staff eyeballed the patient and decided their race and ethnicity or even their preferred language based on first impressions. Some asked patients some questions, but not others. Their approach was always well-intentioned. They did not want to make our patients uncomfortable. And they also didn't want to be uncomfortable themselves. What if a patient asked them, for example, a question that they couldn't answer? It was a solution to get information, and it unfortunately wasn't always the best approach. Luckily, this work is not new to healthcare. So healthcare organizations down the street and throughout the state and the country have laid the foundation for DEI improvement work already. And data is always a top priority. We made the decision to make improvements based on industry best practices, and we educated staff on why this information is important, how it will be used to improve care and the patient experience, and why all patients should be asked about their race, ethnicity, preferred language, versus assuming this information. And to be successful, staff had to understand the why. To be able to address likely questions from patients if they were asked about them. And this past May, happy to share that we started asking patients for enhanced demographic information. This included asking patients about their preferred about their preferred language and if they needed an interpreter. And in addition to race and ethnicity, we are also asking patients about their ethnic background and country of birth. Currently, we have new enhanced demographic information from about 50% of our patients. But we're actively working to improve that number as well. And with a few months of enhanced information available, departments are already looking to evaluate or starting to evaluate options for how they're going to use this new information to help improve patient care outcomes and the patient experience as well. Now, let me introduce to you the HEDIC. This is the Health Equity, Diversity, and Inclusion Council. As mentioned earlier, it's the group that has oversight of most of the DEI improvement work that is happening system-wide. One of the first actions that the HEDIC took was to develop a charter. The charter describes the council's purpose, its membership, committees, and roles. And it has a commitment statement that's highlighted here. It tells you why the HEDIC is doing what it's doing for our patients, our workforce, and the community. And the commitment simply states that we commit to improving the health and well-being of our community, employees, clinicians, and volunteers by fostering equity, diversity, and a culture of inclusivity and belonging. We will meet the healthcare needs of our patients and community by cultivating an environment where people can bring their unique selves to us for safe, high quality, and culturally competent care, and where they and our diverse workforce feel valued, respected, and supported. So this is a HEDIC structure. The council is chaired by our CEO, Kimberly Hartz. The HEDIC has the following 4 committees: the Data Metrics and Compliance Committee, which is co-chaired by our Chief Medical Information Officer, Dr. Brian Smith, and Chief Compliance Officer, Kristen Ferguson. The People, Culture, and Mission Committee is chaired by our Chief Patient Experience Officer, Laura Anning, and our Chief of Human Resources, John Subiena. The Equity of Care Committee is co-chaired by the Director of Rehabilitation Services, Elisa Curry, and Chief of Quality and Resource Management, Mary Boron. And lastly, but definitely not least, is the Community Engagement Committee. This community is chaired by Chief of Community Support Services, Angus Cochran. So these committees are spearheading the improvement work at the committee level, along with small but really mighty teams that include staff and physicians from throughout the healthcare system. Currently, the committees have representatives from the hospital, from the Medical Foundation, and the Service League, and soon we hope have members from Sound Physicians, and in the future hope to have other members of our medical staff as well. And while we have some frontline staff on some of the committees, we're actively recruiting and expect to have more diverse representation from various areas of the workforce. Both the HEDIC and the committees are evolving, and we'll be welcoming new people as we move forward with improvement work. As you can see, it definitely takes a multidisciplinary team to embed equity work into the organization. The work that I'm about to share with you is happening because of all of the people on this slide and many others who support this work on the sidelines. So immediately after forming the committees, each of the committees spent several months conducting an assessment of where we are as an organization as it relates to our equity journey. We used Impact for Health's inclusion scorecard for population health to get us to our current state. And before I proceed, I want to tell you a little bit about Impact for Health. The company was co-founded by Maria Hernandez, a resident of the Tri-City area. Some of you may be familiar with Impact for Health because Maria reached out to the president of this board around the time that we were beginning our DEI journey. She contacted the board as a community member to simply inquire about our DEI work, since she had not seen anything about this in our publications. That inquiry led to us learning more about Impact for Health and their wealth of knowledge in the area of health equity work. Impact for Health works with healthcare organizations locally and nationally, and Maria and her team have honestly been instrumental in our DEI journey. With their support and the scorecard for population health at our fingertips, we have a solid strategy as we move forward with this work. And an impressive element of the scorecard that I want to share is that it is crosswalked with health equity standards from CMS, the Joint Commission, and AHA's Health Equity Roadmap. This means that as we address different items in the scorecard, we're also simultaneously working on meeting Joint Commission and CMS standards, and it's keeping us on the right equity path. So now to the scorecard that you see on screen. Each committee self-rated anywhere from a dozen to 3 dozen items in their respective category, and then it ended up with an overall rating, which is what is shown here, rating from 1 to 4. As you can see, the scorecard indicated that there's good work happening, but we have lots of opportunities for improvement. The committees will be reevaluating elements within the scorecard as work progresses, and we expect that the scorecard rating will be improving with that. So the closer we get to a 4, the further we are on our journey to achieve health equity and equity in the workplace as well. So now I want to share with you some of the committee's priorities for the year. This will highlight the work that is underway at the moment. I'm going to start with the Data Metrics and Compliance Committee. They started their improvement work by enhancing MIDAS. MIDAS is the incident reporting system that we use to improve patient safety and quality of care. Anonymous reports can be made for any patient safety issue, near misses, or adverse events. Anyone reporting in MIDAS can now indicate if the reportable event was impacted by bias or inequity influencing factor. So for example, was the event impacted by race, gender identity, or maybe the event is linked to preferred language? Did we not use an interpreter to communicate with a patient who needed one, as an example? And here's the view of the bias or equity concern option in MIDAS. This option went live this July. And as of last week, there were no reportable events with a contributing factor tied to bias or inequity concern. Next, let me tell you about the People, Culture, and Mission Committee's work. Earlier in the presentation, I shared that after announcing the DEI journey to the healthcare system, we started to take action. We surveyed the workforce. The 2023 Diversity and Inclusion Survey told us a whole lot about people's feelings about our culture and what they wanted to see more of to enhance their work experience. One of the items that came out of the survey is that people want resource groups. Some organizations call them employee resource groups or ERGs. Others call them employee affinity groups and other names. The People Committee of the HEDIC wanted their first priority item to be in response to that 2023 survey. So they are helping create our first resource groups. Notice that I didn't refer to them as employee resource groups. And that's because our group will include the entire workforce, which includes our employees, physicians, and volunteers. On the screen, you see the flyer that the committee used to announce the workforce survey that went out several weeks ago. And now I'm going to show you what we learned from that survey. Our workforce wants to spend more time with each other outside of work, and they want to celebrate the different cultures that they celebrate. We asked about the types of groups that they would consider joining, and these are their top choices. They're marked with the stars here. The committee, with the HEDIC's support, is going to be helping establish 2 groups, a women's resource group and a multicultural resource group. The committee is currently looking for people to lead these groups. And as mentioned earlier, the groups will welcome everyone who's part of the healthcare organization, which includes employees, physicians, and volunteers. And I want to point out that the survey participants indicated a very strong interest in a mental health group. The committee is going to do more research about how to support this type of group. I anticipate that a mental health or a wellness group could be part of our future, unless a better way to to provide these services or this support is identified in a different area of the organization. Now, let me share with you the work of the Equity of Care Committee. The committee is working with the transitional care team to look at readmissions with an equity lens. The transitional care team decided to explore readmissions by looking specifically at the CMS groups listed here. The analysis of the readmissions patterns revealed that pneumonia and congestive heart failure were the largest groups contributing to hospital readmissions. They learned that 64% of the patients were under the care of either a skilled nursing facility or home health agency at the time of readmission. And because of this finding, or because the finding is significant, it is currently being addressed through strategic initiatives aimed at reinforcing partnerships with our skilled nursing facilities and home health care partners. But we were looking at readmissions with an equity lens. So the transitional care team also looked at the racial and ethnic makeup of the patients who were being readmitted. The data revealed that 15% of the patients identified as Hispanic or Latino, indicating a fair representation of this one group. In terms of race, the majority of the patient population identified as white or Caucasian, followed by Asian. Additionally, a significant proportion of patients identified their race as other, further highlighting the diversity within the patient population that we serve. And I must also note that the data evaluated is for fiscal year 24. So this is mostly represents patient demographic information before we rolled out the enhanced demographic questions in late May. And also before education was provided to staff about making sure to ask patients that they provide this information to us. Next, the analysis looked at patients' preferred language. We learned that most readmitted patients' preferred language is English, with 24% of the 118 readmitted patients preferring a non-English language. Of those that selected a non-English language, 82% of the patients did not have documented use of interpreter in their chart. We all know that communicating with our patients in their preferred language is a priority and our policy. What we don't know is whether this pie chart represents poor documentation. For example, our interpreter policy allows staff and physicians who speak the patient's preferred language to speak with a patient without an interpreter. And currently, we don't have a standard method of documenting all of these options in the patient's medical record. But we are making changes to improve documentation for doctors and staff, and we expect the improvements in the coming months. We're also working with our vendors to explore best practices and look into future improvements within the services that they provide us. What is important to note here is that interpreter use is an ongoing priority throughout the healthcare system. We are working to make sure that when the patient's preferred language is not English, that we are speaking with a patient in their preferred language. And with improved documentation and training, we anticipate that this preliminary information will improve moving forward. One final thing about the work of the Equity of Care Committee. Their priority is really to look at care and patient outcomes throughout the organization with that equity lens that I keep on referencing. The committee wants to determine if and where inequities exist, excuse me, which is it's the first necessary step to begin the work of eliminating inequities. And while the focus currently is on readmissions, the plan is to do similar analysis in other areas of the organization. So with better and more reliable patient demographic information, more detailed data stratification becomes an option for us in other areas of the healthcare system as well. And then there's the Community Engagement Committee. This group is working on the best practice that was identified earlier in the presentation. They're developing a community advisory board to further enhance our relationship with the community. So ideally, the board will consist of community members that represent a wide range of lived experiences and identities, including different cultures, race and ethnicities, sexual orientations, faiths, and age groups as examples. And we're expecting wide range of community representation. The purpose of the board is to create an additional connection between the healthcare system and the community or communities that we serve, so that we can have a space for honest and transparent communication about how we're doing. The community board will be asked to be part of our DEI journey by creating that space to hear about the health needs of district residents and a diverse representation of district residents. And we want them to help us identify barriers to care and wellness as well. And we want the board to provide input and advice on the development of the community health needs assessment, health needs improvement plan, which is our roadmap for addressing health disparities in the community health needs assessment. We want the members to provide feedback on our community engagement and health education activities as well. And now I'm going to turn to some of the other improvement work that is underway, because there is more happening outside of the HEDIC. I mentioned earlier that we have been working on improving the use of interpreter services throughout the healthcare system. One of the operational priorities for the last fiscal year was to increase the use of these services. What you see here is the chart highlighting documented use of an interpreter per patient bed days at the hospital. The average interpreter used for the year was 1.466 per patient bed days. And while we got really close to the target goal of 1.5, you can see that in the second half of the year, we met our target every month. We still have a lot of work to do in this area, and use of interpreters when a patient's preferred language is something other than English will remain a priority. In the next couple of months, there's going to be additional education focused on interpreter use, when to use them, how to use the services, and how to document their use in the patient's medical chart. And ultimately, our goal is simple. If our patient's preferred language is not English and the patient needs an interpreter, we need to use an interpreter for all consent and medical conversations. Here's another example of another project. A few months ago, our patient experience officer, Laura Anning, noticed while rounding on patients that many were having food from the outside brought to them while they were under our care. So this led to some speculation about why this may be happening. We looked at the facts and we requested a report to help us understand how often physicians wrote orders that allowed patients to have food from the outside brought to them. Because the practice was noticed in our labor and delivery department, the data analysis also focused on that department. And here are our findings. It turns out that 44% of patients in labor and delivery from January to July had a meals from the outside or home order. The data validated that belief that some patients want different food that we currently aren't offering. The numbers show that patients who identify as Asian, and it was primarily Chinese, frequently had food from outside orders. And almost 50% of Asian patients in labor and delivery have these orders in their chart. So this led to a conversation with our food and nutrition team about the possibility of offering more culturally appropriate food options for this patient population. Simply asking, could we offer Asian-inspired meals in labor and delivery? And the quick answer was yes. The Food and Nutrition Services team is currently developing a plan for making this happen in the very near future. Another important part of the DEI journey has to do with communication and transparency. to inform the workforce about the work that is underway and to have easy access to resources that many have requested, we're launching a new DEI intranet page. So this page is expected to go live in the next couple of weeks and will be a place where anyone who's part of the healthcare system can go for up-to-date information about ongoing improvement work and to find resources to support their DEI work at the department level, or to find out how they can be part of this work, more formal work throughout the healthcare system. And now to the last part of tonight's DEI update, but it's an important piece because it's about regulatory requirements. There are many DEI-related reporting and compliance requirements from the state, the Joint Commission, and CMS, and honestly, a growing list of other organizations that are looking at our equity work. Actively tracking regulations to ensure compliance because these requirements impact areas throughout the healthcare system. And we know that the requirements are growing, so we need to keep a close eye on them. Here's an example of one of the HCI equity requirements. Signed into law in 2021, Assembly Bill AB 1204 created the Medical Equity Disclosure Act, which requires that hospital systems file an annual equity report with HCI. Hospitals are also required to post a link to their equity reports on the main page of their intranet public sites, which means that we have to develop an equity report to post on our website. And the equity reports are due annually by September 30th, starting in 2025. So we have just about a year to start thinking about what that report is going to look like. So this new annual report is required to include data related to patient access, quality, and outcomes by race, ethnicity, age, preferred language, disability status, sexual orientation, gender identity, and expected payer. And the report must also include a plan to prioritize and address disparities for vulnerable populations identified in the data. Luckily, much of the work that is currently underway will help us meet some of the requirements, but we know that there's still a lot of work to be done. And like many of the other regulatory bodies that are requiring similar things of us and other healthcare organizations, the goal is very similar. They are all looking to us. They are looking for health equity to be a priority and for it to be embedded into the culture of the organization, into operations, into how we do business. They want us to understand health disparities on the basis of specific categories like age, sex, race, and ethnicity. And of course, they want us to do something about the inequities when they are identified. And that concludes tonight's update. Thank you so much for your time this evening. Are there any questions?
Yeah. Thank you so much, Gisela. Yeah. Great presentation. I think this is a topic, especially when the workforce is and the patients are all, so diversified. I think, the DEI becomes very important. And unfortunately, I was reading somewhere that there are about 82 bills, anti-DEI bills that were presented in about 28 states in the last year, and 8 of them have come into law. And I think 8 of them were split between Florida and Texas. So anyway, I'm glad that we are doing a great job with this, and thank you.
Thank you.
Thank you.
Thank you. So moving on.
Next is Dr. Soleil. I see him as our Chief of Staff giving the medical staff report.
Good evening, everybody. That was a great presentation. It's always a hard act to follow with these presentations you guys have at these meetings. They're always so excellent. I'll do my best. We'll start off with the medical staff census. We have a total of 667 practitioners on the staff. Of those, about half, or 347, are active. 2 are administrative, 33 are advanced practice providers, such as nurse practitioners and PAs. 98 are ambulatory, 9 are consulting, 14 are courtesy, 2 are on leave of absence. 103 are provisional active, still in the process of getting their full privileges. 12 advanced practice providers are provisional. We have 44 provisional consulting, 1 suspended, and 2 temporary privileges on the staff. In the agenda also, you'll see a list of all the new practitioners that have joined. It's all there for you, and they have been previously presented by Dr. Berry in his credentialing report, so I won't bore you with the details unless somebody has any specific questions about any of those providers. If not, the rest of my report includes things like the events that we're having. We had a flu blitz 2 days ago. That's our annual immunization blitz for physicians. It was held outside the medical lounge. Flu vaccines were provided, and TB testing was given. And that reminds me, I have to get mine read tomorrow, actually. And so far, it looks good. For those who missed that flu blitz 2 days ago, there will be another one in the Anderson Auditorium area at the end of the month. Also at the end of the month on September 27th, we have a medical staff luncheon that will be held in the cafeteria. I think it will be Mexican food. This is one of the quarterly luncheons that we would like to have to just get the staff together and thank them for their service. We had the general medical staff meeting, our quarterly general medical staff meeting last night, and that went well. We had a lot of excellent presentations and gave a lot of updates to the medical staff. The Top Hat Gala, of course, is coming up soon. That's next month, October 12th, to raise money for the MRI. The theme is Little Italy, and we encouraged people yesterday to attend that and participate. Another presentation that was given yesterday was regarding fundraising for the Cancer Center, and we also encourage people to participate in that and to hopefully find some funds within, whether it's personal contributions or from their organizations or medical groups, hopefully to get us to that $12 million goal. The StatRad Nighthawk service took over from ETR, that's the Emergence Teleradiology, a previous nighttime radiology service. That switch happened on August 29th. And so far I've been hearing good things, better turnaround time and better reads. So I think so far we're happy with that. And hopefully that continues. And I believe that sums up what I have. Any questions?
Thanks, Mark. Thank you.
Welcome.
Good night.
Have a good evening.
Thank you.
Service.
Yes, next is Sheila Vijay, our president of the Service League.
Good evening, members of the district board. I extend warm greetings from all the volunteers. I'm pleased to report that for the month of August, 253 Service League volunteers contributed a total of 2,587 hours to the hospital. We recently onboarded 31 new volunteers during our orientation, including 9 adults, 18 college students, and 4 high school students. We currently have over 600 students on our high school wait list. To better utilize their enthusiasm and support, we are actively exploring additional volunteer opportunities beyond the gift shop, lobby, and birthing center. The wait list is currently closed, and the Service League is not accepting new high school applications right now. We anticipate being able to accept new applications in the first half of 2025. The Service League participated in the Heart Health Fair at Nakamura Clinic on Saturday, September 7th. We had a good turnout, and I'm pleased to report that many attendees expressed their desire to join our volunteer team. Several individuals signed up to show their interest, and we will be contacting them shortly. We have recently been approached by the Washington Hospital Center for Wound Healing and Hyperbaric Medicine with a request for volunteers. We are currently evaluating the possibility of opening the wound clinic for volunteer opportunities, which would provide an additional way to support patient care. This weekend, Evangeline Imana Iamura, our Director of Volunteer Services, and I will be traveling to San Diego for the California Hospital Volunteer Leadership Conference. We will participate in a panel discussion about the successful reopening of our gift shop post the COVID-19 pandemic, including the strategies we used and the challenges we faced. We look forward to bringing back valuable insights and ideas from the conference to enhance the volunteer services. That concludes my presentation. Please let me know if you have any questions.
Thank you. Thank you, Sheila. Wonderful.
Thank you.
Yeah,
We've got to find more opportunities for them.
All right, next it's my pleasure to introduce Dr. Kadir Halimi and Michael Platzbecker. They're going to be giving tonight the annual report on the emergency department. To start with, I'll just introduce Dr. Halimi. He is a dedicated leader in emergency medical practices and community engagement. He currently serves as a medical director for both the Washington Hospital Emergency Department and the Tesla On-Site Clinic, and is a board member of the Emergency Physicians Associates, EPA. Dr. Halimi has held significant leadership roles, including serving as the chair of the Department of Medicine and as the current chair of the Department of Emergency Medicine, or Department of Medicine and the Department of Emergency Medicine, which I know just formed recently. Yes. He has also served on and chaired many committees at Washington Hospital, demonstrating his broad involvement in hospital administration and improvement initiatives. Dr. Halimi's educational journey began at the University of California, Davis, where he earned a Bachelor of Science degree in psychology with a minor in philosophy. He continued his studies and attended medical school at Western University of Health Sciences in Southern California and completed an emergency medicine residency at Texas A&M University. He is board certified in emergency medicine since 2005. And of course, many of us know he's a big 49er fan. I had to put that in there because I know you said that. All right, so let me just quickly introduce also our Michael Platzbecker, our Director of Emergency Services. He's been with Washington Hospital for over 31 years. Michael is a registered nurse with a master's degree in nursing and is a certified emergency nurse. He is currently the Director of Emergency Services with oversight of the Emergency Department and Neurovascular Services. He was previously the nurse manager for the Department and ED Observation Unit. So I am going to turn it over to the two of you to give the presentation this evening.
Thank you, Ms. Hartz. Michael, I think you're going to share the presentation?
No, the AV is going to do it.
Okay. Thank you, Ms. Hartz. Thank you, board members, and everyone in the room for giving us a chance to present our annual report for the Emergency Department. We certainly take pride in presenting our data and presenting the work that we do in the Emergency Department collectively. Next slide, please. So our mission really in the Emergency Department is to serve the community by providing high quality care, clinical excellence, and efficiency in the Emergency Department. In our the slides that we have unfortunately have a lot of data, and I'll be just kind of hitting the highlights to kind of for the interest of time. Our emergency department has 39 beds that are 100% private rooms, and in any event that we need to, we could always double occupy those, so we could actually go to twice the number. We are a STEMI and a cardiac arrest receiving center. We're a primary stroke receiving center. Of course, everybody knows as of the fiscal year 2025, we are also a trauma center. Our specialty services are provided by the hospitalist. We are pediatric receiving center. We have ED social workers to help us with care coordination and behavioral emergencies, which is an excellent service that we have, and is one of the unique services that we have at our emergency department here at Washington and for the Tri-City community. Of course, we also have a SART team and a SART team of nurses that help those unfortunate that need their services. Our physicians are 100% board certified, and since being a trauma center, we're also all certified on ATLS. Since this being a new program, we just want to kind of all start on the same page. Our nurses, I said this multiple times. We have the best nurses at Washington Hospital, bar none. I mean, I work at 4 other emergency departments part-time, and bar none, where we have the best nurses, and that goes to Michael and Lisa and Betty and Terry for helping us hire and retain nurses of high quality. 80% of our nurses are, have bachelor's or higher, as you can see. We have nurse practitioners, some that are whole doctors and masters, and are TNCC certified, CN certified, of course, SANE certified. So again, to me, our core is our nurses and our staff, and we have a great team to work with. And I do want to thank everybody for making us be a great team and helping us practice in the emergency department. Next slide, please. So one of the things that we looked at, when we had COVID, our volumes, as that most of the country, kind of dipped and went down. So since then, not only have we rebounded from pre-pandemic times, but we've kind of gone to historical highs. As you can see, in fiscal year 2022, 23, and 24, we've gone from 53,000 patients up to 60,000 patients. That's 7,000 patients annually that we've increased. Our daily census have increased, of course, and although our admit percentages have stayed about the same, but if we're seeing more patients, that means more admits into the hospital. Next slide, please. So looking at our volume, and one of the things that we've actually noticed, me and Michael and Lisa were talking about, is the level 1s and 2s, or the low acuity patients that we're seeing. And this, to me, and for what we're seeing on a day in, day out basis, is there's less and less availability of community clinics. If you ask a patient to go follow up at their primary clinic, they call, they say, "Doc, I called," and it's 3 weeks, 4 weeks, 2 months for a next appointment. So they end up using the emergency department as a safety net, not only for their emergencies, but for their basic health needs, hypertension, diabetes, medication refills, because they simply cannot see a primary care physician. So we're not only an emergency department, but we've become the de facto primary care clinic as well. And that's something that we're hoping to, in the future, help the community with these clinics so we can have better access to care. Next slide, please. Despite our historic metrics, some of the metrics that we track have stayed strong, and that's partly because we've increased our staffing in the front half of the emergency department, where we call the rapid treatment unit, and triages are. So if you look at our room 2 medical screening exam, our internal benchmark is 15 minutes, and we're well below that at 6 minutes across all 4 quarters. Our arrival discharge time, our CMS benchmark is 200 minutes, and we've been way below that at 170, 181, and 177. Admit to order for departure. This is an area where we need to work. As I alluded to in the previous slide, we're admitting more patients, we're admitting sicker patients. Therefore, we're holding more and more patients in the emergency department. As a result, our door to departure times suffer for that reason. Next slide, please. So some of the challenges we've had with throughput, and just to define borders. Borders are defined as any patient greater than 4 hours from admit order to departure. So anybody that's here 5 hours, 6 hours, they're technically termed as borders. So if you look at fiscal year 20, 22, 23, 24, our number of admitted patients have stayed about the same, from 9,700 to 10,528. But if you look at the number of boarded patients, it went from 890 to 1,900, more than doubled, right? So we've had more than doubled number of boarding patients. And that's, of course, increased number of cumulative boarded hours, and our percentage of boarders have also doubled from 9 to 18%. And again, that's because we're admitting sicker patients, we're admitting more patients. And now that we've become a trauma center, our utilization of our beds have gone up. So for example, we're required to keep 1 or 2 beds empty at all times, right? Because for trauma, in case a trauma rolls in, we've had 3, 4 traumas come in within 5 to 10 minutes. So we need rooms available right away in case they walk. We've had walk-in stab wounds. I was working 3 days ago, we had a walk-in stab wound that came in. So we need to have certain open up some beds and keep them open, right? So our boarding really negatively impacts our admitted length to stay, our discharge length to stay, our left what I've been seeing in our unload offload times. Next slide, please. So despite facing some of these challenges, we've really worked hard to try to maintain the high quality and high efficiency that we can, as much as we can in the emergency department. And we've done that by doing, my computer just froze, by doing PDCAs in the emergency department, looking at how can we improve our front and triage times, enhance surgical care responses, dedicated phlebotomy space, kind of near triage when we order tests outside, imaging studies, including non-contact CTs. We've reallocated a second triage nurse, an APOD office nurse. I think Michael will talk about our APOD process. We have signals on the visual signals on the trackboard to see, patients that come in, who's walking, who's coming in. We've collaborated with our EMS supervisors. Hey, we're completely impacted or we're not impacted. Here's where our staffing is looking like, to help kind of time the surges and really better prepare some of those surges and deal with them. We've also worked with our supervisors to try to get our admission orders in as soon as we can before the shift change, so they can better prepare for shifts at nighttime or the next shift or what have you. Next slide, please. Quest for Zero, this is an annual initiative that we participate in. We've since I've been here in 2004, and shortly thereafter we started doing Quest for Zero. And again, this year we did Quest for Zero, and we got our award. I think I saw a picture of Terry and Lisa in Los Angeles getting the award again. So congrats. This is our 13th consecutive year getting a Tier 2 award. This year we did our quality initiative for sepsis. It was actually a really good module for sepsis. It was so well done that I had not only our doctors at Washington do it, but I had all the other physicians at the other facilities do the sepsis module voluntarily, because it was really well done and really talked about recognizing bias, multidisciplinary team approach, core measures for sepsis, how do we overcome them, engaging and improving. So it was a really, really well done module for sepsis. And then hopefully next year we're going to do a quality initiative and also a prenatal safety collaborative, which will include things like calling back, postpartum hemorrhage, standard order sets, and peripartum hemorrhage in OBs. And of course, the other thing we'll talk about is trauma preparedness for maternal patients coming to the ED. Next slide, please. I think this is where Michael takes over. Michael, you have the board.
All right. Thank you, Dr. Alimi. It's ironic you mentioned the walk-in stabbing, because we had another one about 3 hours ago. But I'm going to take over for Amlin's APOD offload time. Basically, this is a statewide initiative. It's codified now by AB 40, and it talks about the length of time it is before the paramedics hit our parking lot, essentially, and until we accept care of those patients. Alameda County EMS, which is our local EMS agency, which conferred trauma designation for us, has stipulated that 90% of patients will be offloaded in 30 minutes or less. We had a departmental goal to get the 90th percentile down, which means 90% of your patients are offloaded by 50 minutes or less. By June of this year, we were able to get it down to 46. And if you look on the graph, these are the highest volumes we've ever had for EMS arrivals, and we hit 1,500 in January of this year. And despite that, we averaged less than 25 through the fiscal year 24, and we've maintained that even with trauma volume. And we had 1,100 patients roughly in August, and we were at 26 minutes offload time. To achieve that, it's kind of a multifaceted problem. It is not only an ED and organizational issue, it's a community issue. Primarily, there are a lot of challenges there, but it's a volume and capacity mismatch. We have 39 patients. As Dr. Alimi said, we need to try to keep one open for trauma at all times, but that becomes difficult, so we do some room shuffling. But our average hourly census was 35 for fiscal year 24. The census was over 39 in the ED, 10 to 12 hours a day, and it wasn't infrequent that we hit 50. This last week we hit 50 patients 4 hours for the 7 days of the weekly period that ended on Tuesday. A couple of things we've done is we had a modified lean workshop, which included some ancillary lab and x-ray representatives, frontline representatives. and Jimmy and a few other people, Jimmy Chang and Dr. Alimi, and we worked on how do we decrease this, and we were trying to do it in a fiscal responsible manner. So we carved out a dedicated APOD treatment area. We had a dedicated APOD nurse who can do other things, but can get those ambulance patients offloaded in a pretty efficient time. We worked with Walter. I see Walter on the Zoom call to try to do increased testing for our waiting room cohorts, so that by the time they come to see a physician, the physician can make a decision quickly and dispo them. Yeah, a couple other things we really did. We worked with Falk. We have a really good relationship with our 911 provider, and we have a huddle between the ED charge nurses and the Falk zone supervisors, so they can keep each other kind of abreast of conditions within the hospital as well as out in the community, and that's worked well to kind of even out the load a little bit for our ED. ED stroke, we're a primary stroke center, as Dr. Halimi mentioned. In calendar year 2023, we had an increase in the number of patients we saw, and also an increase in the administration of the thrombolytic therapy, the clot busting drugs. This is 2023 data because this is official Get With the Guidelines stroke AHA data. We had a significant improvement plan to kind of reduce that thrombolytic door to needle time. And that's important because time is brain. And as you can tell, we've decreased the time down to just over 30 minutes for calendar year 2023. Next slide, please. I do want to mention on the stroke as a more timely measure, the first 2 quarters of this current calendar year, AHA recommends that you give the thrombolytic therapy door to needle time within 60 minutes. For the first 2 quarters of calendar year 2024, we've actually hit it 100% of the time. Not only that, 45 minutes we've hit 100% of the time, and we have an expanded goal of 30 minutes, and we actually hit that almost 70% of the time. So we're continuing to work on that, and that'll be realized in the next, the metrics for the next year. Another important program we have here is the sexual assault response team. We're one of 2 centers. The other one is Highland, and it provides an important service for the district residents, so they don't have to travel out of our area up to Highland to obtain services for this unfortunate episode. And it is part and parcel with, it's considered a trauma, so it is important as a trauma center that you have this particular service. Next slide, please. Another important program we have in collaboration with CalBridge is the substance use disorder program. We have an embedded Sun navigator who gets consults based on the patient's chief complaints. We'll talk to the patients about opportunities to reduce any negative effects from substance abuse, deaths primarily from fentanyl and fentanyl-like drugs. As well as getting to connect them with links to the community for substance abuse disorder treatment. And as you could tell, we started in March, and we've maintained about 30 patients that we've referred out through that time. Next slide, please. Patient experience obviously is an important endeavor for us in ED. It gets incredibly difficult to do when we're busy. Luckily, since we're coming out of the COVID fog, we've transitioned to allow 2 visitors at the bedside, which fosters more of a family-centered environment. A few of the other measures we did to increase our likelihood to recommend and staff work together is we do leadership rounding. Lisa and I and Betty round on the patients. Our charge nurses have started to take that up as well. In addition, it really helps when the nurses, which is unusual, it's a paradigm shift for ED nurses to do this, is you go into the room together and the oncoming and offcoming nurses actually introduce themselves. They ask the patient, what's one thing they can do for them now? And that seems to be really well received and connect the patients with the nurses. And we also discuss our weekly press gaining results at our huddle. Next slide, please. All right, probably the overarching focus for this past fiscal year, not the only one, but the overarching focus was preparation for our adult trauma 2 designation, which we successfully, with a lot of help, achieved. We participated in the medical staff development committee, the trauma operations committee, And we participated preemptively before we were trauma center in the regional trauma center meeting and the Alameda County Contra Costa trauma center meetings, just to develop the network connections that we need as a trauma center. We've created and revised numerous protocols and policies related to trauma. Staff preparation was a huge endeavor, not only for the ED, but housewide critical care in 6 West and numerous other departments. We had a TNCC class, which is the minimum certification for Alameda County for the nurses, and 90% achievement rate now. But by the end of September, we will only have one of our current nurses who will not have TNCC certification. Dr. Alimi and some of the other ED physicians did medical minutes related to trauma. We had some impromptu trauma-based simulation exercises. HIMSS is a helicopter arrival, so we had some simulation exercises with the helicopter crews as well. We recognize the nurses that did get certified. Another important thing was just to get our EMTs in the ED used to trauma. We facilitated ride-along experiences with them through Falck EMS. Next slide, please. Some of the things that we did to facilitate that learning, obviously, is the TNCC class. The 48% staff training rate was up until July, but as I mentioned, we're much higher than that now. But this is a hands-on didactic class, and it's taught by experienced trauma nurses. And it's the minimum level that you need for trauma. Next slide, please. Some of the other modalities were the IO drills, which is that drill that you see there. Quick clot is a dressing that you can apply, but it needs to be applied correctly to stop hemorrhage and bleeding. Belmont is a rapid infuser, so we can deliver blood quickly and safely to patients with penetrating injuries. As Dr. Alimi mentioned, it's important for the physicians to be ready, and they're 100% either ATLS certified or recent within 5 years residency trained. One thing we did is we, through our networks, we were able to bring on a couple local trauma nurses. I'm not going to say from which trauma center, but they're extremely experienced trauma nurses. They are instructor certified, which means we can do instruction, the TNCC classes, which is an ongoing thing as well. Internally, we don't have to reach out to a contracted service. And it does have a revenue opportunity because one of our classes later in the month actually has some internal non-Washington candidates paying for the class. Next slide, please. Next steps, we've got a lot of them. Obviously, we're just new to the trauma center designation, so that's an iterative process. So we're working closely with the trauma team, Jen and Ginger, to improve, what we're doing with the trauma. APOD timeliness continues to be an ongoing concern for us. We're working with the case management team, and that's a portal of entry nurse to make sure that the patients should qualify for admission and they're admitted to the right level of status inpatient or OBS, and we're trying to coordinate more outpatient care. We really want to improve the mid-order to inpatient timeliness, and we're proud of our LWBS rate because it's one of the lowest in Alameda County. Patient experience is a salient goal for us. We're looking at likelihood to recommend, staff work together, and staff cared about you. And as I noticed, we're doing a lot of warm handoff and leadership rounding for that. Obviously, the culture of safety and staff engagement is huge for us. We are cognizant that, that we have a fiscal responsibility. And so we were trying to reduce on our end, not Dr. Alimi, but on the nursing staff to reduce the mill penalty and premium pay. And finally, our strategic map, obviously, we need to enhance our trauma care coordination and our upcoming American College of Surgeon certification status, and also our pediatric readiness. Next slide, please. Well, thank you for the time. It was really pretty difficult to condense the ED work for a year into 10 minutes or less. So hopefully we didn't go too fast, but if we have any questions, Dr. Alimi and I would like to answer them.
Any questions for Dr. Halimi or Michael?
Thank you. Thank you, Halimi and Michael.
Go 49ers.
Bye.
Thank you.
Thank you.
All right, to begin with having Tom McDonough, our VP and CFO, to present the financials for July of 2024.
Thank you. I am delighted to present the hospital's financials for our first month as a Trauma 2 hospital. And it is, I would say, the entire system has responded well to this new chapter. It's been a learning curve in July, and we're getting there, and we look for bigger and better things as we move forward. July, inpatient average daily census was 161.6 on a budget of 166.6, so off about 5. Discharges, 959 on a budget of 933, so some outperformance there. Patient days, 5,009 on a budget of 5164, so slight shortfall about 3%, 155. Observation equivalent days were 380 on a budget of 383, so small outperformance there. Average length of stay was 5.73 on a budget of 5.53, so some underperformance of about 20 basis points. Case mix for July was about 1.61 on a budget of 158. About 3 basis points of outperformance. Deliveries, 125 on a budget of 125. Surgical cases, 508, 30 better than budget of 478. Cath lab came close. Budget was 180, we had 173, so about 7 off there. Outpatient visits, 8,932 on a budget of 8,238, so nearly 700 outperformance on the outpatient visits. ED visits were 5217 on a budget of 5120, or 97 more than budget for the month. Here we have the breakdown of the surgical cases. Ortho outperformed by 35 cases in the month of July. This is mostly due to the ortho group that is on call here from UCSF. Cardiac surgical cases, small outperformance of 13 on a budget of 10, and then endoscopies outperformed by 28 at 131 total for the month. On the cath lab side, you can see 27 on 40, or 13 cases on peripheral vascular underperformance. Outperformance in cardiac, 95 on a budget of 85. Non-vascular came close, 40 out of 49. And then neuro-IR way overshot the budget at 11 versus a budget of 6. Operating indicators, productivity. Productive FTEs came in at 1,425.5 on a budget of 1,484.3, so outperformance there of 58.8. And then non-productive FTEs came in at 223.3 on a budget of 234.3, so again, some outperformance of 11. So total FTEs for the month of July were 1648.8 on a budget of 1718.6, or 69.8. Total FTEs per adjusted occupied bed, which is a metric using discharges, came in at 5.97 on a budget of 6.15, or 18 basis points of outperformance. Gross patient revenue came in at $220,300,000 on a budget of $209 million, so $11.3 million of outperformance on the gross side. Contractual allowances came in under budget at 74.53 versus a budget of 75.26. Provisional bad debt and charity went up in the month of July from budget, so we were at $4.4 million on a budget of $3.8 million. So all in, total deductions came in at 76.51% on a budget of 77.09. Next, we have the GASB abbreviated income statement. And again, GASB stands for the Government Accounting Standards Board, which we are subject to. So here again, I'm going to take us to the third line, net operating revenue. So after the contractuals we just reviewed on the prior page, net income for the month came in at $52.9 million on a budget of $49.3 million. So just over $3.5 million of outperformance. However, you can see the 7.3% increase over budget. Expenses came in at $53.6 million on a budget of $49.4. So underperforming there by $4.2 million or 8.5%. And so expenses did better than our revenue. Leaving us with a net up.
Why? Yeah. What caused the variance?
So a couple of things. We had the RIF that occurred.
The early retirement.
Early retirement, sorry, my bad. Early retirement that occurred, and that was about a $900,000 one-time payment for those people that took the early retirement out. And then we also had a $1.5 million one-time recognition for the ETO payouts. And then that will earn that back over time. So there were two one-times of about $2 million.
Yeah, it just seems like in the first month after of the budget, we'd be off that much.
Yeah. But if you take those one-times out and the ETO payouts, because when people hit their cap on ETO, they're automatically paid that out. That was also $500,000. And so it was just the timing as opposed to, supplies came in on budget and some other things. But these one-times came in July. On the non-op side, third line from the bottom came in at $2.4 million on a budget of $369,000. So strong outperformance, giving us a net income for the month of July of $1.7 million on a budget of $242,000. We now take a look at it from a FASB standpoint. So FASB is what applies to public and private companies and organizations. So if we looked at it from that perspective, our net operating income on the fifth line down came in at a negative $1.1 million on a budget of $744,000. And then when we add in the non-op, instead of the $1.7 million pickup, we would be sitting at about $100,000 net income, negative net income or loss for the month. EBITDA for the month of July was $2.648 million on a budget of $3.34, or about a $700,000 variance. The percentage of EBITDA came in at 5% for the month of July on a budget of 6.8. That concludes the July report.
Thank you.
Any other questions? As Tom said, we did have some one-time costs that we had to recognize in July versus in the previous year from that standpoint. But I am going to move forward with providing the preliminary numbers for August of 2024. As you can see, we tried to highlight the numbers August in terms of in that box. Patient gross revenue of $220.8 million for August was favorable to the budget of $212.1 million by $8.7 million or 4.1%, and higher than August 2023 by $23.1 million or 11.7%. You can also see to the right of the chart, there's the year-to-date revenue, which was favorable to the budget by 20.1 or 4.8%, and favorable to last year's to date by $52.9 million or 13.6%. Also, want to give a little bit more information on the trauma cases. You can see trauma cases of 138 for August was favorable to the budget of 103 by 35 or 34%. Year-to-date cases was favorable to the budget by 54 or 26.5%. Inpatient trauma cases of 47 for August was unfavorable to the budget of 63 by 16 or 25.4%. And outpatient trauma cases of 91 for August was favorable to the budget of 40 by 51 or 127.5%. So at this point, we had thought in terms of budgeting, we've seen more outpatients than inpatients right now. We'll have to see how that trend continues. Again, this is the first year that we are a trauma center and worked with the consultants and others, but we'll have to see in terms of how that plays out. You can see breakdown. This is the trauma cases for the month that's broken down by activation code. Each trauma case is coded at a certain level based on specific guidelines that are followed by all trauma cases or trauma centers. They're broken down. Alpha is the most acute, then comes Bravo, and then comes Delta. So you can see the 138 cases that we saw in August was broken down by 12 Alphas, 39 Bravos, and 87 Deltas. So we are seeing an uptick in terms of the number of Alpha cases that we have seen, but also we see that the Deltas too, a high number. Looking at our preliminary trauma gross revenue, it came in at $13.6 million for August, was favorable to the budget of $13 million by $605,000 or 4.6%, and year-to-date revenue was unfavorable to the budget by just $293,000 or 1.1%. Again, inpatient total trauma gross revenue of $9.6 million for August was unfavorable to the budget by $1.8 million or 16%, but again, outpatient trauma gross revenue of $4.1 million for August was favorable to the budget of $1.7 million by $2.4 million. So it's pretty much evened out. Going back to the preliminary inpatient gross revenue as a whole, it came in at $125 million, which was favorable to budget by $2.7 million or 2.2%, and $13.8 million or 12.4% higher than August of 2023. Looking at outpatient gross revenue, it came in at $95.8 million, which was favorable to budget by $6 million or 6.7%, and $9.4 million or 10.8% higher than the August of 2023. Our average length of stay did well this month. It came in at 4.93, was favorable to the budget of 5.57 by 0.64 or 11.5%, and that average length of stay was lower than the August 2023 average length of stay of 5.47. I think we haven't seen that low of a length of stay in more than 2.5 years. So, and you'll see too that we don't have any patients longer than right now in the house longer than 30 days. Yes. Looking at outpatient observation equivalent days of 370 were favorable to budget of 408 by 38 equivalent days or 9.3%, and shorter than August of 2023 by 12 equivalent days or 3.1%. Looking at our inpatient average daily census, it came in at 146.5. It was unfavorable to budget of 163.2 by 16.7 or 10.2%, but higher than August of 2023 average daily census of 146 by 0.5 equivalent days. Average daily census for trauma was 5.8 days. But again, as we continue to work on that length of stay and having patients stay the appropriate level, we'll also see some of that in our average daily census. In terms of discharges, though, our August discharges of 968 were favorable to budget of 909 by 59 or 6.5%, and were 91 or 10.4% more than August of 2023. And again, as mentioned, we didn't have any patients that were over 30 days. Looking again at our next is our patient days trend. Patient days came in at 4,545, which was unfavorable to budget of 5,059 by 514 days or 10.2%, but were 20 days or 0.4% more than August of 2023. And again, some of this is due to having less than budgeted inpatient trauma cases. Also, as we work to continue to ensure that we have our patients in-house, the appropriate length of stay, you'll see our patient days also go down. Just to say, our ICU days came in at 469. That was favorable to budget. OB and special care nursery were also favorable to budget. Our IMC, telemetry, and med-surg were the areas that were unfavorable to budget. We had a busy surgical month for August. We had total surgeries that came in at 544. They were favorable to the budget of 495 by 49 or 9.9%, and they were 14.5% more than August of 2023. Our inpatient surgeries of 257 were favorable to budget by 4 or 0.16%, and 19.5% more than August of 2023. Our outpatient surgeries at 287 were also favorable to budget by 45 or 18.6%, and 10.4% more than August of 2023. Now you can see the breakdown of our surgical activity. As you can see, we had a busy orthopedic surgery month. We had both Dr. Saw, Dr. Dearborn were above budget. As you can see, we're above budget by a variance of 52. We came in at 207 versus a budget of 155. As I mentioned, Dr. Dearborn and Dr. Saw were both over budget, but also the UCSF ortho trauma surgeons did 53 cases. So they were also very busy this month. You can see our neurosurgical volume was below budget by 16. We did have one of our neurosurgeons that were out a number of days in the month. Our cardiac surgery cases came in above budget by 6. That also includes 5 TAVR cases that we did during this month. Vascular surgery was also above budget by 7, along with endoscopy, but other surgery was below budget by 22 cases, and that was over a number of areas. Moving on to our cath lab, you can see August cath lab cases of 199 were favorable to the budget by 7 or 3.6%, and were 3.1% more than August of 2023. Our cath lab inpatient cases of 105 were unfavorable to the budget by 6 or 5.4%, but more by 6.1% than August of 2023. Our outpatient cases of 94 were favorable to the budget by 13 or 16%, and consistent with August of 2023. Next slide, you can see the breakdown in our cath lab activity. Again, our cardiac cases came in at 129, which is a variance of 35 above our budget. Our non-vascular IR cases and our peripheral vascular cases both came in under budget by 16 cases. Our IR physicians did not perform to the budget number, which was driving down the non-vascular IR cases and also the peripheral vascular cases. But our neuro IR cases came in at 9 compared to our budget of 5, so above budget.
2 months in a row.
So both Dr. Raper and Dr. Thomas both. Moving on to deliveries, we had a very busy month for deliveries. We came in at 149 deliveries for the month. They were favorable to the budget by 29 or 24.2%, and were 15 or 11.2% more than August of 2023. So we do see very much sort of that up and down with deliveries here. Moving on to the non-emergency department outpatient trend. Visits came in at 9,031, which was favorable to the budget by 320 or 3.7%, and more than August of 2023 by 72 or 0.8%. Basically, we saw favorable to budget in the areas of lab, imaging, and infusion. All of them, those areas came in over budget. Moving on to our emergency department. I know we've heard a great deal about emergency department this evening. It did come in at visits at 5,095. They were unfavorable to the budget by 315 or 5.8%, and were though 175 or 3.6% more than the prior year. So didn't quite make budget, but was higher than last August of 2023. Moving on to looking at our gross revenue recap. As you can see, once again, it came in total gross revenue over budget by 4.1%. Surgical services revenue was favorable to budget by 1.5 million or 3.9%. Cardiac cath lab revenue again came in above budget at 36%. Our room and board, just given the number of patient days and our length of stay being lower, came in below budget by 5.2%, but with the birthing center also with that volume high came in over budget by 19.5%. Emergency department, even though was below budget in visits, came in above budget in gross revenue by 16.6%. And really that was driven by not seeing as many of the lower level cases in the emergency room and seeing more of the higher level, the 5s and the 6 in the emergency department. And again, also because of trauma, and the majority of the cases are outpatient cases versus becoming inpatient cases too. Then lastly, ancillary revenue was favorable to budget by 2.5 million, and primarily we've seen a high utilization of CT services in that. Looking at our preliminary payer mix, overall in terms of total government payers came in favorable to our budget at 73.7%. HMO came in at 2.6%, which is favorable to the budget of 1.8%. PPO came in favorable, or I would almost say right on budget at 21.2% versus a budget of 21.1%. Our VA TRICARE came in just unfavorable to budget and came in at 0.9% versus a 0.8%. And lastly, private pay did come in favorable at 1.6% versus 2%. All right, moving on to our productivity indicators. I will say that the graphs up that I am showing are the right graphs in terms of the August numbers came in at 1,436.3 to a budget came in favorable to the budget by 24 or 25 FTEs, and that's the productive FTEs. Moving on to the non-productive FTEs, also came in favorable to budget, came in at 191.7 compared to a budget of 199.5. So together, looking at our total FTEs, they did come in under budget, so favorable to budget by in terms of 2% at 1,628 FTEs. So we did, at least in terms of focusing on, we continue to focus on making sure that we're at budget or below budget as much we can. And there's certain areas that we are focusing on specifically in terms of bringing those areas within budget. Moving on to Radiation Oncology Center, we did break down the types of treatments that you can see. We did come under budget in August. They came in at 264 or 132 cases or 33.3% unfavorable to the budget of 396. Just we're looking at each of the types of cases. The green ones are the standard radiation types of cases. The blue ones you can see are the SRS or SBRT, and that's really mainly where rays are delivered in a very precise manner to receive the dose of radiation to the cancer area. And then we also break it down by IMRT, and those are really the beams of radiation that are customized or shaped to match the shape of the cancer. So we can really follow in terms of the areas of treatment. But really turning to the next slide, you can see our Radiation Oncology Center consults, because that really tells sort of the volume that we're looking at into the future. And we did have a healthy month in terms of both referrals and for consults. In August, you can see we received 45 new referrals that came from various sources, and we also saw in the clinic, we saw 26 new patients, and again, they will convert into treatments, and we see about a 29% conversion rate. So we're following, even though our treatments were lower, we are looking at continuing to see the volume of referrals and visits coming into the clinic. Moving on to Whitmouth, the clinic visits came in at 17,219. It was unfavorable to the budget in August by 2.4%, but 2.8% higher than August of 2023. This was mainly driven in terms of our primary care and mainly focused on pediatrics. We are in the process of recruiting for another pediatrician, and so our visits were off in pediatrics, and we also had a couple of physicians in primary care that had unanticipated time off during the month. Then moving on to Development Corporation, our outpatient statistics, visits came in at 2,458, which were favorable to the budget by 154 or 6.7% for August, and were 27.4% more than the prior year. Our three main entities are Washington Outpatient Rehab Center. Their visits were favorable to budget by 107 or 6.4%. Our Washington Outpatient Surgery cases were favorable to budget by 38 or 7%. And our Peninsula Surgery Center cases were also favorable to budget by 9 or 10.5%. So those entities were busy in August. Moving on to our financial statistics and charity care. Days cash on hand came in for August, ended at 128 days. It was a decrease of 3 days from the prior month. That was mainly driven by two items. The first is that was a 3 pay period month, and so for our medical foundation and other entities, we had higher working capital than usual in this month, and then also we made a payment to Aon for our renewal of our insurance premiums that came in at about 1.85. So between those two, that is we also did a good job in terms of continuing to bring in the cash, and so that helped us in terms of not going down any further. And then for charity care, we saw just $79,000 in charity care adjustments for August of 2024. So really seeing in terms of the work that we do in terms of ensuring that or finding whether or not our patients do indeed have some level of insurance. So year-to-date adjustments were at $476,000. So that's for the month of August, the preliminary statistics. Are there any questions?
Can we track payer mix and write-offs separately for trauma?
We do. Yeah, we are looking at that. So very much so. So we do track a separate. The payer mix for trauma is different than the overall hospital payer mix. And so, we felt maybe on a quarterly basis we could show that, because right now it's a little bit in terms of fuzzy. Yeah. And yes, in terms of private pay for trauma, that is higher. I think we've budgeted around 8 to 9% for that, because also there are times when there's, and what I'm told, and Tom, please, there are times that they start in private pay, but then, like if somebody's in a car accident, then it's, the insurance companies later on that have to get paid. So there is that then moves from private pay up to one of the other payers too. So, but we did budget, or I believe, is it around 9% in private pay compared to what? Yeah.
Later on.
Yeah. Okay. Yep. Good question. Any other questions? All right, let's go on in terms of, I want to now start with Employee of the Month for September, and that it's my pleasure to introduce you all to Martha Letty, as we all know her, Perez, and she is Employee of the Month. She joined our healthcare system in 2016 as a business assistant in the perioperative department, where among other tasks, she worked on staff scheduling and time card reconciliation for more than 130 employees. And I should say, really, right now, where she is, she's our one of our payroll associates in general accounting, and I think many of us know her very well. Letty enjoyed the work and her colleagues when she was previously in the perioperative department, but when COVID happened and her children were forced to learn from home, she needed to find a remote work opportunity. So in November of 2021, Letty was left, and then she came back, and she returned to Washington Hospital as a payroll associate working with Gloria Bonilla. Letty added to her previous experience and soon became proficient with all facets of payroll and preparing payroll transmission for more than 2,200 employees. Her role requires attention to detail and knowledge of many job codes. She ensures employees are being paid at the correct rate for the correct role. Letty often receives calls or emails from timekeepers throughout the organization requesting assistance. She approaches these inquiries with a customer service focus, and I know Cheryl has talked to her quite many times. Letty is also a strong team player. She consistently demonstrates her willingness to cover or take on additional workloads. Training new team members is another area where she excels. She takes on an active role in onboarding and mentoring new staff members, providing them with the knowledge and tools related to payroll and ADP. Her approach to training is both thorough and supportive, ensuring that new hires feel confident and well prepared for their new roles. This commitment to impactful training contributes successfully and significantly to the department's overall efficiency and effectiveness. So congratulations to Letty Perez. All right, moving on to the health promotion and community outreach events for previous month. As you can see, I'm just going to pick out a few of the highlights here. We were busy in the community. As you can see, on August 28th, Dr. Jack Rose presented stroke warning signs and risk factors, and he had 729 total views on Facebook and YouTube, so very busy. The other one I want to just highlight is September 7th, and we hosted the Union City Heart Health Fair. I think many of you know that in our 2023 Community Needs Assessment, it really revealed the high level in Union City that we had of heart disease, stroke, and blood pressure. So Angus, Cochran, and many others came together and collaborated with 11 community organizations in Union City and put on a health fair that was focused on bringing awareness and education on cardiac health. And I know it was very successful, and as you can see, there were over 300 attendees, 100 glucose, cholesterol checks, and 86 blood pressure checks. So I just want to thank everybody that was part of that great event there. You can see some of the pictures from some of the other events that we did attend. And here's our Union City Heart Health Fair, and Dr. Sagal, one of our cardiologists, was there with staff and many others too. Then we did have our Employees Association's Family Fun Picnic at the Aqua Adventure Center on August 17th, and many families enjoyed that. Just want to talk just briefly and mention some of the upcoming health promotion and community outreach events, and all of these, most all of these are listed on our website if you'd like to get more information on them. We are out in the community doing education on a number of different areas, and do want to just also highlight on September 25th, Dr. Shariat, one of our critical care intensivists, will be talking about sepsis and what is it and how we can increase awareness on both Facebook and YouTube. Moving on to that, next we'll be also in the community with supporting New Haven School Foundation on the Mutt Strut at the Masonic Home. We participate quite a bit in that. Our trauma team is going to be at Cal State East Bay, Hayward, for Science in the Park. And then we'll also be talking about breast cancer surgery, what are the options on Facebook and YouTube. I want to just pause. I know you actually heard a little bit about this from Dr. Halimi in his remarks. I do want to say that Beta, our malpractice insurance, recognize the healthcare system with 3 awards. We received the Quest for Zero Excellence in ED, as Dr. Halimi discussed, and really these awards are focusing on a journey around patient safety and best practices, and he talked about the education around sepsis recognition and treatment protocols. The second award that we received was Quest for Zero Excellence in OB, and this really focused on fetal tracing education and adoption of best practices in fetal monitoring. And not only the hospital received it, but the Medical Foundation also received it for their focus on education and clinical judgment around electronic fetal monitoring. So I wanted just to say that, and then moving on, and congratulations to everybody who participated and worked hard for us to receive those 3 awards, and thank those areas. Also in the Healthcare Foundation, I know Dr. Saleh mentioned, our Top Hat Gala is on Saturday, October 12th. The funds will be supporting the purchase of a wide-bore MRI that will be in our Morris Hyman Critical Care Pavilion. Also, scholarships were awarded for the Dr. Asali Scholarship last month to 2 students pursuing higher education in the field of medicine. The winners were Juan Ernesto Vaquez, Giaro, who is pursuing a master's in nursing at Cal State Sacramento, and Shannon Lee, who is studying medicine at UC Davis. And lastly, the Charitable Foundation will hold a special luncheon on September 17th in special recognition of all those individuals who've joined our Legacy Society. So that is the operations report.
All right, I think we have 2 action items.
Yes.
Director Yee.
Oh, you want motions now? For the first action item A, consideration of the architectural fees, Phase 3 building of the facility master plan. President, I move that the Board of Directors authorize the Chief Executive Officer to execute the contracts necessary for Radcliffe Architects to proceed with the next phase of the project in an amount not to exceed $2,956,493.
Second.
All right, I'll talk a little bit about this. As we all know, we went to our community, and our community has supported us greatly in terms of general obligation bonds that are going towards this next phase of our facility master plan. It's to meet the seismic requirements and the growing needs of our community. So we are beginning that design phase. We've done some work in terms of just some layouts for this building, and we need to continue down the path in terms of that next phase of the design, the schematic design phase. But again, it's a building about 200,620 square feet. We're looking at a 4-story building that will hold the remaining of the units that will move from the hospital tower over to this new building. So we'll have and also other departments, our clinical lab, our cath lab, IR, endoscopy, of course, kitchen, cafeteria. We'll also have our OB and NICU there, along with our med surg. So we'll be talking more with the board about the actual design of it, but we'll also be bringing back a full budget, of course, for that project, that feel that we wanted to come forward requesting this next phase in terms of the design fees, the architectural fees. So,
Kimberly, I do need to do roll call for the motion.
Yes, we do it afterwards.
Yeah.
Yes.
Okay.
Now we do it. Yes, we're still in the discussion.
Okay.
Yep.
All right.
Yeah.
So just a question.
Yeah.
When will the plans be finalized? What's the anticipated date that architects will be done?
Yeah, so we hope to bring sort of the schematics to the board in the next couple of months, but then it will take them to after schematics, they need to finish up the construction and all of that documents, and then it will need to go to HCI and then from there. So, we've got some basic general plans, but now we do want to come back and discuss and then bring it forward. So, yep.
Let's begin.
Okay, Cheryl.
Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Aye. Director Stewart?
Aye.
Thank you.
Yeah.
Yes, as you know, we've got the seismic deadline out there, but we are moving forward.
Okay. The second action item, consideration of closure of the pediatric department due to low volume and availability of quality pediatric care at nearby specialized institutions. Mr. President, I move that the Board of Directors approve the recommendation of the Chief Executive Officer as stated in the memorandum.
Second.
So I'd like to spend a little bit of time and talk about where we are and how we got to where we are in terms of the recommendation, and I'll be specific in terms of the recommendation. So as all of you know, we're very much committed to providing the highest quality patient care to our community. And I will be explaining the recommendation that I am making for the closure of the hospital's inpatient pediatric unit. This recommendation comes after in-depth and careful consideration and is really supported by two factors. That's first is the consistently low volume, and secondly is the availability of high-quality pediatric care at nearby specialized pediatric institutions. And I also do just want to recommend that part of this whole thing is that we continue our commitment to providing the pediatric care in the emergency department and also through key services in partnership with UCSF Health, and I will be outlining those below. But in terms of low volume, over the past year, our pediatric unit has seen a significant decline in pediatric admissions. We average about just 13 patients per month, which is about 0.42 patients per day. Also looking over this past month, our department has been closed about, on average, 18 days per month. And so the low occupancy is far below the level needed for operational efficiency and financial sustainability. And the decline really is attributed to advances in immunizations and the ability to manage pediatric care in the outpatient settings or specialized pediatric hospitals. I think all of you know that very close to us we have Lucile Packard Hospital, and we also have UCSF Benioff, both in Oakland and Mission Bay. And these, both institutions are equipped to provide excellent pediatric care. They have all the subspecialties that are needed to provide care to pediatric patients, and they also have all the other resources that are needed to make sure that the family and the pediatric patients are cared for in the appropriate manner. So although I am recommending the closure of the pediatric department, again, our commitment to pediatric care at this healthcare system is very important and is part of along with our relationship with UCSF Health. And so, in terms of, I just want to be clear, in the birthing center, the nursery, and the emergency department will continue to provide the care for our newborns and for our children. So if a child needs to have care, they can come into our emergency room and get the care that they need. As you heard from Dr. Halimi, we have a pediatric readiness that both all of our staff and our physicians are trained and will continue to be trained to care for our pediatric patients. Also, if any pediatric patients come in and need inpatient care, they will be assessed, and if needed, we've been working with UCSF to develop protocols that are needed for that smooth transition to pediatric hospital, whether it's Benioff or also, of course, Lucile Packard too. We will, as I said, continue to operate our 10-bed level 2 nursery. We are also in the new building, as we just mentioned. We're looking at potentially even expanding the bed capacity in that new building. We will also maintain on site 24/7 pediatric hospitalists, thank you, that will be, one of the UCSF pediatric hospitalists will be here, so they will be able to take care of any patients that come into the emergency room, also, of course, in the level 2 nursery or on the floor, too. So we're continuing, again, to take care of all the pediatric patients that need the care that they, in our emergency room. So my recommendation is that we move forward with closing the pediatric unit no later than October 1st, 2024. We will communicate plan to inform our patients and our families and our community about this. We will also be working with our 3 full-time and 10 per diem nurses to identify similar positions within our birthing center and level 2 nursery if they so choose to continue to work at the healthcare system. And again, as I said, we also recommend that we continue our commitment to providing the pediatric care where I've mentioned. So again, this was not an easy decision, and it was one that was not made lightly, but one that we discussed in many thorough manner too. So I request the board support and approval to move forward with the proposed plan.
Yeah.
Any questions?
I pretty much, would second this, and, being a pediatrician and worked in the community for about 30 years, the national trend, or maybe even a global trend in the last 14, 15 years is pediatric admissions all across have been decreasing by 25-30%. And what they've also found is the very few admissions that they have are very much higher in acuity, which needs more specialized care. And I think 90% of the admissions would definitely need specialty consults. And all the pediatric consults are just around Palo Alto Children's Hospital, Stanford, or Oakland Children's Hospital. So, they'll be much well served if the patients are admitted in one of those. It's just about 26 miles north is Oakland Children's, and about 19 miles southwest is Stanford Children's Hospital. So, we are in the so close, proximity to both this. So we are blessed with all that, and, which I tell always my patients, we are so blessed that you've got 2 of the best children's hospitals in the world around here. So, and also in 30 years, I don't think I've made any direct admissions to Washington Hospital, because any patient who really needed admission either went to Stanford or Children's. And that's also a trend that they found now, that about 70% of the admissions, pediatric admissions, although the volume has gone down, but 70% of that is all newborn-related admissions, which we have a newborn, in level 2 nursery, so, that which can take care of all that. And it's only about 18% of the patients are, health-related, which I just said, most of them needs, specialty consult. So I think the community will be definitely much, better served by this decision. And, like you said, we have got a 24/7 pediatric hospitalist. So even if a severe acute patient comes, it can definitely be stabilized here and still, transferred. So I think I would definitely second.
Okay. Yeah, and then one thing I didn't mention was those babies that are less than 30 days old that do need to get readmitted for something like jaundice or something to that nature, we will be admitting them to the level 2 nursery. So that is something, thank you for bringing that up.
In fact, they were even admitting, a lot of my patients we born in, Highland Hospital, and who had high levels of jaundice, they always took them in here instead of sending them to Highland. So I think the community is, well served, and I don't think they're going to have any issues.
So, are there any other,
Roll.
Ready?
Director Epen?
Actually, there's a
Director Waller?
motion on the floor.
Yeah, there is.
Okay.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Yee?
Aye.
All right, so that passes. So you have some announcements.
Yeah, I do want to also just make one announcement. We had to make some incredibly tough decisions on September 3rd in terms of we moved forward with a reduction in force for the healthcare system. I think you saw the financials where we ended fiscal year 24 on a consolidated basis. We ended at negative about $14 million. That is better than that we did the previous year, where we also had a pension hit, and we were over $39 million in terms of that. So we've made improvements. We've been working hard in terms of looking at ways that we can increase revenue and also decrease costs. That we can't just decreased our way out of this in terms of expenses, we've got to look at both sides. We've made, yes, we did an early retirement program that we talked about earlier. And all of those things we've been working on have been making a difference, but that just wasn't enough. And so, again, I made the incredibly tough decision to do the reduction in force. We had 25 employees that were impacted, and again, it's the positions that were impacted. 20 of those were benefited, and 5 of those were per diem. There are a couple of areas in terms of our stroke program. I just want to say that those nurses and the function of the stroke program is not going away. We're just training others to be able to recognize and treat stroke patients. We're actually on our journey to become a comprehensive stroke program, and so we are moving in that way, and so we are no less committed to our stroke program with that move. Again, we will have more nurses that are trained to be able to take care of stroke patients, not only in the ED, but on the floors. Another area is pulmonary rehab was another area that's impacted. We are continuing our support of the Better Breathers group that meet on a monthly basis here. So that is not going away. That is an important community support group, and we are continuing that. We're also continuing our pulmonary function test. It is what we have been seeing is a decline in outpatient pulmonary testing, and that is outpatient visits that we are going to be closing that area. And again, it is really tough decisions that we had to make, and those are just some of the areas that were impacted. We're continuing our commitment to our lean, though it's going to be everybody's responsibility, that continuous process improvement. But I wanted to make sure that the board was aware of some tough decisions made this month. So, thank you.
Thank you. So where would the patients would need some pulmonary testing, where would they go to?
So we're still doing pulmonary testing, but if they have outpatient visits that are needed, we're working with the pulmonologist in terms of, we have a few pulmonologists in this community in terms of where to work with them to get what they need in terms of that. So we're in that process, yeah. And those are, I should also say that's not closing until November, because we want to make sure all the patients that have been scheduled are getting treated. So that until the middle of November, so.
Anything else?
No, that's it.
Well, there being no further business, the meeting is adjourned.